Our research focuses on the critical intersection of socioeconomic status and healthcare utilization. As shown in our roadmap, we will begin with our introduction, establishing why this is a vital policy issue. We will then walk you through our methods, outlining how we synthesize current literature. Moving into our results, we will discuss the specific themes and data patterns we observed. And finally, we will conclude with our discussion, where we interpret these findings and offer a conceptual framework that will show how these socioeconomic statuses cause disparities, and also will offer up future policy interventions to help healthcare move forward. And our goal is to move beyond simple statistics and examine the marginal implications of these health disparities. The core of our study addresses a persistent challenge. Despite legislative efforts to expand insurance coverage due to the ACA, socioeconomic status remains a fundamental determinant of health that dictates the very pathways patients take through the healthcare continuum. We've identified a significant issue, as we call the functional access gap. This is the reality that having insurance does not necessarily or automatically mean that a patient can navigate or use the system effectively. Our research objective is to examine how socioeconomic drivers like health literacy and geographic areas, or as we would like to call care deserts, shift patient behavior from high value preventative services towards high cost acute intervention. This is a critical issue for healthcare administrators because failure to mitigate these social determinants results in unsustainable costs and poor clinical outcomes across our most vulnerable population. To ensure our findings were robust, we conducted a comprehensive review of peer-reviewed sources across databases like PubMed, JAMA, and NIH. We utilize specific key terms such as health inequities and emergency care to capture the full scope of the utilization cycle. Our methodology was inclusive of various study types, from meta-analysis to qualitative studies and field experiments, allowing us to see both the broad statistical trends and the individual patient experience. And then we extracted data specifically on socioeconomic indicators like income and education, and this helped us see recurring patterns within those indicators. And with this rigorous thematic analysis, it ultimately allowed us to develop a conceptual framework to inform on future policy research.
Across the 28 studies included in this review, socioeconomic status consistently emerged as a major predictor of health outcomes. Half of the studies directly linked low socioeconomic status with worse health compared to higher socioeconomic groups. The evidence shows a clear social gradient in health, meaning that health improves step by step as socioeconomic status increases. Individuals in lower income groups face higher rates of preventable disease, such as type 2 diabetes, cardiovascular disease, and mental health disorders, such as substance use and psychotic disorders. Research also showed that children from low socioeconomic households are significantly more likely to experience developmental and behavioral conditions, such as ADHD. These patterns are consistent worldwide. Studies from the United States, Japan, India, and China show that lower income adults experience more disability, functional decline, and barriers to care. Across countries, factors such as cost, insurance coverage, education, and geographic access all influenced health outcomes and healthcare access. The first major theme that we identified was biological weathering and multimorbidity. Low socioeconomic status acts as a long-term physiological stressor. Chronic stress from food insecurity, housing instability, and financial pressure creates what researchers call allostatic load, or long-term wear and tear on the body. This stress produces a cycle where poor health and financial instability reinforce each other. Even individuals who achieve higher income later in life often carry a lasting health penalty from childhood poverty. So studies suggest that a significant portion of adult health disparities can be traced back to early life economic conditions. Research also identified a predictable disease cascade among lower income populations. Mental health conditions often appear first, followed by chronic physical illnesses such as liver disease, heart disease, lung disease, and eventually cognitive decline. As a result, lower socioeconomic populations experience higher levels of multimorbidity and greater clinical needs over their lifetime. The second theme that we identified was the safety net paradox, which describes major differences in healthcare utilization. Higher socioeconomic groups tend to use a preventive care model, including regular checkups, screenings, and specialist follow ups. This proactive approach often leads to better outcomes and lower long term costs. In contrast, lower socioeconomic groups often rely on a reactive care model with significantly higher use of emergency departments. Many emergency visits among vulnerable populations involve conditions that could have been treated in primary care settings. Figure 2 shows groups who are more likely to experience lower socioeconomic status consistently have lower rates of preventive care use compared to higher income populations. This reflects the structural barriers that limit access to routine care. Emergency departments therefore become a reliable source of care for vulnerable populations. Figure 3 shows emergency department visits broken down by whether ED level care was actually needed. The ratio of preventable ED visits is actually the highest among minority populations, but the figure also shows that a large portion of ED visits across all groups could have been treated in primary care settings. This demonstrates how limited primary care access pushes many patients towards emergency services. Hospitals often provide faster and more comprehensive care than primary care offices, which reinforces the reliance on emergency services. As a result, the ED becomes a safety net for vulnerable populations, even for conditions that could be treated elsewhere. However, this system reinforces reactive treatment rather than prevention. The third theme identified was material bottlenecks, which refer to structural and logistical barriers that limit access to healthcare. Healthcare financing systems often create unequal access. Wealthier patients can obtain higher quality care, while lower income patients face insurance limitations and out of pocket costs. Many patients delay or avoid care altogether because of financial barriers. Transportation emerged as another major barrier through our research. Access to a car was identified as one of the strongest predictors of healthcare utilization, and missed appointments due to transportation issues often lead to poor chronic disease management. These challenges are especially severe in rural areas where provider access is limited. Figure 4 highlights the differences within low socioeconomic groups themselves. The figure compares individuals who frequently use emergency departments with those who use them less often. Frequent ED users reported major social stressors such as family dysfunction, housing instability, food insecurity, and substance use. In contrast, lower frequency ED users often reported structural barriers such as lack of insurance and employment pressures. This comparison shows that emergency department use is not simply a matter of income level, it is strongly shaped by social instability and life stressors. The fourth theme is double gatekeeping, which includes both systemic bias and patient self gatekeeping. Systemic bias within healthcare contributes to unequal treatment. Studies show that patients who are perceived as having higher socioeconomic status are more likely to be offered appointments for preventive care services. Racial and minority groups, particularly Black Americans, experience disproportionately poor health outcomes linked to both socioeconomic disadvantage and structural inequities. At the same time, patients may engage in self gatekeeping, avoiding preventive care due to mistrust or negative past experiences. Many low income patients report feeling disrespected or dismissed in healthcare settings. Healthcare systems also place heavy demands on patients through complex insurance systems, multiple appointments, and complicated treatment instructions. This creates what researchers call treatment burden, which disproportionately affects lower income groups. Health literacy plays an important role as well, with many low income patients unaware of available services or unable to navigate complex systems. Overall, these results demonstrate that socioeconomic status functions as a structural determinant of health, not simply a measure of income. Low socioeconomic status influences health through multiple pathways: biological stress, healthcare utilization patterns, structural barriers, and systemic bias. Together, these factors create a system in which health outcomes are shaped not only by medical need, but by a person's ability to access and navigate care.
Preventive care requires resources and stability that individuals with lower SES may not have. Lower SES is associated with reduced preventive care and higher ED utilization. High ED utilization is a result of system level access limitations rather than inappropriate use of acute care. Individuals with lower SES may also perceive the ED as less expensive and more comprehensive than primary care. The social determinants of health are the conditions in which a person is born, grows, lives, works, and age. They're broken into 6 categories, and they include things like access to nutritious food, the community that they live in, social integration, income level, education attainment, and all of them together represents a person's health behaviors. Barriers to preventive care include things such as being uninsured or underinsured, having a lack of transportation to and from the doctor. It also includes things such as cost sharing or indirect cost, which is copays, deductibles, the cost of having to miss work, or the cost of childcare while they go to the doctor. It also includes health literacy. Individuals with lower SES are more likely to have lower health literacy, and lower health literacy reduces the amount that they understand their health, and they're more likely to receive worse treatment. Individuals with lower SES also report that discrimination is a barrier to preventive care, and they're more likely to be discriminated against based on their income or the type of insurance they have.
One of the biggest takeaways from our research is what we call the recursive utilization cycle. Think of this as a loop that is very hard to break. It starts with the basic factors like a person's income or education. These factors go through filters like whether a person has a car or they trust their doctor, and these filters push patients into 2 different paths. One path is high value, where people get their regular checkups and stay healthy. The other path is low value, where people wait until they are in crisis and have to go to the emergency room. This loop is recursive because an ER visit is very expensive and can lead to missing work, which makes the person even poorer, pushing them right back to the start.
Our recommendations for reducing ED utilization and increasing preventive care for individuals with lower SES include things such as removing barriers by offering transportation assistance, expanded clinic hours, minimizing cost sharing, and increasing health campaigns to support health literacy. Healthcare systems should also educate their providers on biases to reduce discrimination. We found that penalizing ED usage with increased cost would just lead to worse health for individuals with lower SES and is not a real solution to reducing ED utilization and increasing preventive care. Our conclusion is that improving preventive care access rather than restricting emergency care is essential for health equity and better health for individuals with lower SES.